For the next talk, we have Dr. Abhilash Chandra. He's professor and head of Department of Nephrology at Dr. RML Institute of Medical Sciences, Lucknow, and he's speaking about fate of access around transplantation.
Good evening to all. Thanks to the organizers for inviting me to talk on this topic. I'm extremely grateful for the hospitality offered. I was given this topic, fate of access around transplant. So what I thought and what it meant possibly was that what to do with the access we have for dialysis when the patient is going for a transplant. So are there any guidelines? Practically, there are no guidelines in this regard. We all know that renal transplant is the most definitive and the cost-effective option when compared to keeping the patients on dialysis. But we all are aware that patients are on RRT in the form of dialysis or HD or PD before they are taken for transplant. So first, we can discuss fistula, which is again one of the most common entity used for dialysis, hemodialysis. So what does fistula does to our body? It raises the cardiac output to almost from 5 liters per minute to 6.5 liters per minute. So when we have a patient who is getting dialyzed through AVF, we don't have any guidelines to actually decide what to do with that fistula. So what do? We actually teach the patient to monitor the signs for any occurrence of pain or swelling, new swelling, or a change in the size of fistula, or to appreciate any change in the thrill which is there in the fistula. So in order to decide what to do with that particular fistula, we need to know what are the endpoints which the fistula is going to have on our organs, primarily the kidneys and the heart. So a fistula creates an environment which leads to a decline in blood pressure. It decreases the fall in GFR, and in terms of cardiac impact, it increases the cardiac oxygen demand, increases cardiac output, it increases venous return, and it favors an eccentric modeling of the left ventricle. But what if we ligate the fistula? So if we ligate, we see a decrease in left ventricular end diastolic diameter. It decreases left ventricular mass as well as mass index. But it also has some negative impacts, like it raises the diastolic blood pressure, increases TPR, raises pulse pressure, and at times it may lead to worsening of GFR as well. So we need to keep these things in mind before we decide what to do with a fistula, running fistula, in a patient who is undergoing a transplant. So are there any studies? There are a few studies which studied the outcome of patients who underwent a closure of fistula. One of the studies is from Vickers et al. They showed that there was a decline in GFR in patients who underwent a closure of fistula versus who didn't consider for a closure of fistula. This was another study by Letachevich et al., where studied the implications of functioning fistula on blood pressure control and renal allograft dysfunction. And they showed that presence of fistula led to a slight decrease in diastolic blood pressure, but no impact on renal function as such. Another small study by Mason et al., and they showed that in the event of a closure of fistula, there was a rise in diastolic blood pressure to the tune of say 4 to 6 millimeter mercury, and there was a decline in NT-proBNP, and the most important findings were that it led to a decrease in end diastolic volume, decreased left ventricular mass, and left LA volume as well. So cardiac impact was quite significant. So in order to answer all these questions, there was a meta-analysis which looked into both these factors, the graft outcome as well as the blood pressure and the cardiac effect of closure of fistula. This was done by Zhang et al., published in 2020 in Annals of Vascular Surgery. They included 10 studies in this meta-analysis, and they showed that patient who didn't have a running fistula had a slightly higher blood pressure. So sorry, in not having a fistula, they had a lower blood pressure, but and also they had a lower left ventricular mass index compared to those patients who had a running fistula. And when it came to creatinine values, those who didn't have a patent fistula had a lower creatinine value as compared to those who had a patent fistula. So this was a different outcome as compared to the earlier quoted study. One of the studies looked into the factors which led to a closure of fistula, and they reported that the Steele syndrome was the most common entity which was responsible for a late ligation of fistula, followed by aneurysm and cosmetic reasons. So if we club all these studies together, what do we make out? Surgical ligation can be attempted, can be found in special indications if you have a high running fistula, high flow fistula more than 1.5 liters per minute. If you notice an arterial Steele phenomena, or if you see that patient has a high cardiovascular status and is running a risk of entering into a congestive heart failure, you can still consider a surgical ligation of fistula while taking the patient for a transplant. But whenever you consider for a closure of fistula, you need to consider the threat of a graft dysfunction at a later stage and a possible return to HD when you may require a new fistula. And particularly if you have exhausted the peripheral veins for earlier fistula making, creation of a novel fistula could be a difficult thing to do. So you have to consider all these factors into mind. What about tunnel catheters? Tunnel catheters are also quite commonly used, but the data regarding the tunnel catheter in the use of tunnel catheter in the peri-transplant period is again all the more scarce. There are no guidelines as such. So how do we handle tunnel catheters? The best approach possibly would be an active surveillance of infection. You can do a blood culture maybe 2 weeks prior to taking for a patient for a transplant. If you are giving antibiotics blocks, it's good enough. They have shown to reduce the incidence of catheter-related bloodstream infections. So you can continue with antibiotic locks. What about prophylactic antibiotics? There are no guidelines as such which could suggest that use of prophylactic antibiotics helps in reduction of CRB size in the transplant period. So best option is not to use prophylactic antibiotics, because unnecessarily you may be selecting the resistant bacteria. The most commonly taken approach is to keep the catheter in place for 1 to 2 weeks post-transplant to see for any possibility of delayed graft function, where you may need the access to be there for dialysis. What about PD catheter? PD catheter, again, there are no specific guidelines, but some societies have suggested that the PD catheter can be kept as long as up to 3 months, so that you almost negate the possibility of possibly requiring a dialysis in the post-transplant period in the case of graft failure or a delayed graft function. In some have said that it can be kept to 6 weeks, and some have also suggested that if you are taking patients for a live renal transplant where the risk of delayed graft function is anyhow very low, you can still consider removal of the PD catheter right at the transplant itself. So main factor which is to be considered while keeping the PD catheter in situ is the likelihood of a delayed graft function occurring post-transplant. So people have studied keeping the PD catheter in case of a delayed graft function where you have used PD catheter for PD, and they found that when they compared the patients who were kept on hemodialysis versus those who were on PD, the outcome was same in terms of graft failure. The same study also studied the length of hospital stay, which was similar in both the modalities, be it PD, be it HD. And in terms of duration of delayed graft function, it was again almost parallel. So the modality didn't have any effect on the graft outcome as such in cases of delayed graft function. One of the studies took around 137 PD patients, but they had a poorer outcome. They said that almost in 15 patients requiring post-transplant PD, almost a third of patients developed peritonitis and 20% developed fluid leaks. So they suggested that it's best to remove the PD catheter and opt for a hemodialysis if you at all require a dialysis post-transplant. This is a study by Peluso et al. They showed that the risk of catheter infection is pretty low, and they suggested that you can keep the catheter as long as to 30 to 45 days, and then you can possibly remove the PD catheter when the possibility of graft failure is anyhow very low. This was a meta-analysis done by Zabrovsky et al., where they included only 8 observational studies. They be minded. This was not a collection of randomized trials. It was a collection of observational studies. So the level of evidence was pretty low, but they still studied it. They studied 2 factors as to how many catheter-related infections are there, and the possibility of requiring dialysis based on the fact that whether the catheter is kept in situ or not. And they found that if the catheter was kept in situ, the likelihood of requiring dialysis post-transplant was almost twice as high compared to patients who had the catheter removed. They also studied the risk of peritonitis, and they said that it's almost to the prevalence of peritonitis was almost to the tune of 6.3%. So even in the presence of these evidence, they said that the studies had an inherent bias, because PD catheter in situ was there in particularly in those patients who were more likely to require dialysis or more likely to have a delayed graft function in post-transplant period. So there was an inherent bias in most of the studies. So level of evidence was still low. So can we sum up the findings in the earlier studies and to decide whether should we keep the PD catheter in situ or not? So first you need to assess the risk for delayed graft function. If there is no risk, like taking patients for live related renal transplant, so you can anyhow remove PD catheters right at the transplantation itself. But if there is a risk, you need to assess whether the peritoneal membrane was breached during transplant, or were there other surgical issues related to PD catheter being left in situ, or there was a high risk of peritonitis or PD catheter site infection. If any of the factors is there, then it's best to remove the PD catheter then and there itself. If no, then you can keep the PD catheter in situ and use it in case you require dialysis. A small data from our own center. We had this is the data for roughly around 200 patients. Our patients are mostly from the younger age group. 37 years is the mean age. We had predominantly male patients in our setting with the dialysis vintage around more than a year. We had running fistulas in almost 157 patients in 200. And tunnel catheter was there in situ in 28 patients. Temporary catheter was used for dialysis prior to transplant in as many as 10 patients. And PD catheter was there in just 5 patients. So if we talk in terms of outcome, this is just a 4-week outcome. And we noticed that there was an access thrombosis in as many as 32 patients. And the removal time of the tunnel catheter was around 8 plus minus 4 days. So we keep the patient for 2 weeks in our KTU. So this is by the time they are set for discharge, we remove the tunnel catheter. We remove the temporary catheter a little early. All PD catheters were removed at the transplant time itself, at the time of transplantation itself, because we are only doing live related transplant. So anyhow, we don't expect a high rate of delayed graft function in our setting. What about infections? This has been the most talked about when you keep the catheter in situ for so long. We had 3 CRBSI episodes in tunnel catheters. All were managed with antibiotics and removal of catheter, and there was no mortality reported. In terms of temporary catheter, we just had 1 episode of CRBSI, which was again managed by antibiotics and no mortality reported. There was no tunnel infection or peritonitis because we had all the PD catheters removed at the transplantation itself. So to conclude, AVF closure at the time of transplant can be considered if EVF closure leads to improvement in NT-proBNP levels and the cardiovascular profile, but it also leads to an increase in diastolic blood pressure. So closure can be considered taking all these factors into mind. Change in AGFR slope in various studies after EVF closure has shown mixed results. So possibly it's difficult to base our decision on GFR slope as such. Maybe availability of more scoring scales could lead to a better decision making when it comes to closure of fistulas, which includes a global cardiovascular risk assessment as well. And keeping PD catheter requires a good assessment of DGF risk, PM membrane, peritoneal membrane breach, and the risk of peritonitis. Thanks for patient listening.
Thank you, Abhilash, for a wonderful presentation. Just one question. Is there any international data available for spontaneous closure of fistula post-transplant? And what is the median time to spontaneous closure for fistula? Most of the patients have, according to your own study, almost from 200, you had almost 35 patients with spontaneous closure by 4 weeks. So almost 20% of patients already have a spontaneous closure of fistula. So why not ligate the fistula post-transplant? What is the benefit there?
First, the data. Data is there. In the immediate post-transplant period, if we take say around 2 months of post-transplant period, the international data suggests that is roughly around between 10 to 15% of patients are, in fact 8 to 15% of patients are likely to have a spontaneous AV access thrombosis in immediate post-transplant period. Later on, roughly additionally 10 to 20% also notice spontaneously closure of fistula. So the other question was why can't we just close it? Closure requires again assessment of a possibility of graft function, or how long are you going to have this graft. Say the survival of a graft is roughly around 50% at the end of 10 years. So how the patients are likely to require dialysis again. So whenever you think of a closure of fistula in the transplant period, you always think that what if he requires this access in the event of a graft failure. So the suggestion would be that if you didn't have a history of multiple access failures, then you can accept for the graft closure or the fistula closure. But if you had exhausted other peripheral access sites, then it's best to keep the fistula running as long as possible. So, and of course, in addition, you also need to take into consideration the cardiovascular profile of the patient. So if it allows, we can still consider for a closure of fistula, but the most important factor which should be there in your mind is the possibility of graft failure in the later years of his transplant period.